Right, well, welcome to the Northern Regional Trauma Network Paediatric Trauma Evening. This is the first education evening of its sort run by the Northern Regional Trauma Network.
It's your time.
There's someone at the door. So what's happening here is that we're teleconferencing round to 4 other centres. So welcome all you people down in Southland, Christchurch, Waikato and Middlemore, I think.
We've got 38 sites on here.
We've got 38 sites. Wow. Brilliant. First of all, I think I better start with thanks and acknowledgement. So thank you to the Northern Regional Trauma Network and, as by extension, to the Major Trauma National Clinical Network. So these are the networks which have sponsored this event, which have made it free for you tonight and provide supper and everything. So thanks to them. And you'll find out what all those funny words and titles mean in the first talk by Ian Civil. And secondly, thanks very much to Matt Sawyer. Matt's the trauma coordinator at Starship Hospital, and Matt is responsible almost entirely for this evening. It was his idea, brainchild, and he's organised it and done the brilliant Twitter feeds and everything else. So thanks, Matt. Thank you to all the speakers who have come here and given their time to chat to us tonight. And most of all, thank you to you guys for turning up. And to all the people around the country. You'd be interested to know that we thought we'd book out the little room next door here, and we sold out the first 70 tickets in 12 hours. So it must be a bit like organising a Miley Cyrus concert, I guess. You've got to go online and click. But so we thought we'd extend it into the lecture theatre here and sold out the 200 places in 3 days, and we've got 60 on the waiting list. I think there are 90 people down at the Christchurch site who are teleconferenced in, and as you've heard, there's lots of other centres. There's also people who are looking at some live feeds at home. I guess before I go on, some housekeeping. Please don't turn your phones off, but please put them on silent. So you'll need your phones in the last session for your quiz, and Matt will explain that to you later on. I think that the phones will work better on data, not on Wi-Fi, if that's okay, from testing. No food and drink in the auditorium here, and toilets straight out the front door, turn right, and if they're full you can go up or down the elevators and find toilets in exactly the same place on other floors if they're full at the break. The program tonight, there's first of all 3 talks in the first session, followed by a supper, and then 3 further talks, and we'll end with a quiz run by Matt and Aidan, which will be a lot of fun, so please stay for the quiz, and we'll be finishing at 7:30. So without any further ado, I'd like to get on with the first session, and may I introduce Professor Ian Civil. Ian is the clinical lead of the Major Trauma National Clinical Network. Ian is the head of trauma services here at Auckland Hospital, and trauma services have been run for how long now, Ian?
23 years.
23 years, the first adult trauma service anywhere in New Zealand. In fact, the first trauma service was set up by and Colby before that. But Ian has been the president of the College of Surgeons. He has got a huge record in academia. He's a professor of surgery. He's on the editorial board or editor of numerous journals. And I'm not allowed to go on, but I do have to give you one interesting fact. Ian is the grandfather of 2 children, hence the title of his talk, maybe. Thank you, Ian.
Thanks very much, James, and let me just figure out how to get from A to B. And thank you very much for this huge attendance in trauma. It is absolutely gratifying that this many people are interested in educational activities within trauma. So we just have to find my talk. It's probably that one there. Yeah, I think so. Yeah. I'm glad somebody else is doing this, because I would feel bad doing it. All right. So I think the title was actually given to me by Matt, actually, so I don't take credit for that. But this is to put perhaps what you're going to think about in terms of paediatric trauma in the context of the wider network, which is worth reflecting on, and James has reflected a little bit on the length of the trauma service. And I think as we do what we do today, we should just reflect on some of the things that have preceded us and, in fact, what trauma care used to be like. If you look back to the 1970s, when most of you weren't born, I can confidently say, looking around this audience, there wasn't a trauma system as we think of one today. Injury prevention initiatives were limited, and some of the road traffic crash prevention initiatives that we think of as being standard. I think you're going to block out bits that, can you take it out altogether? Yeah, that's good. Weren't in existence. There weren't median barriers on any of our highways. There were no airbags. There was no, there were dangerous things like lap seat belts in the back. And there were none of the standard injury care initiatives that we think are common today, such as the trauma courses. And our road death rate was an all-time high of, in the high 20s per 100,000 per year. That's that peak in the 70s. And at a clinical level, injuries were addressed by the priority of the individual there, so that you may be really great and have great training and give your own version of trauma care, which was fantastic. Somebody else may have much more limited training, and there were no guidelines to help make sure that the quality of care was the same. As a result, there were significant variations. If you looked at our road safety record back in the 80s, it didn't get much better. It come down to 21 per 100,000 per year, but we were well ahead of the pack. And just reflect now, it is somewhere in single figures. It's about 7 or 8. It was 7, it's just gone up to 8, I think, in the last year. And if nothing had changed, based on road crash alone, we would be having 1,443 deaths in 2017. But fortunately, things did change. First, for the worse, if you look at the old Auckland Hospital in the 1980s, and in the 1980s, children who needed resuscitation came to Auckland Hospital. The old Princess Mary didn't have resuscitation facilities, so you'd go there if you're sort of sick, but if you were really sick and needed resuscitation, you came to Auckland. You were managed in DCC up until, I think, about 1991 when Starship opened. And the numbers were going up, and our results were bad by today's standard. We thought they were good. Just shows you perspective. I did a study in 1983 looking at trauma patients that came into the resus area at Auckland City Hospital, and 223 of these patients, 60 of them died. Mortality 26.9%, but we were really good, at least so we thought. Now, if our overall mortality is over 10%, we're not good. We're trying to track Victorian target, which is around 6%. New Zealand Major Trauma National Clinical Network, I might have this somewhere later on, mortality for the last rolling year to the end of August was 8.9%, but I will show you some paediatric figures, and you would expect that the paediatric numbers are somewhere less than 5%, which is expected. And what did people die of? They died of what we would now generally consider preventable injuries. They died of hemorrhage. You can see there 32% of the deaths were as a result of hemorrhage, which is just not something that we see today, fortunately. So a lot of things went back and forward. Initiatives came, initiatives went. ACC bought planes, initiated trauma centres. ACC chief executives got indicted, and things went backwards. Things went back and forward, back and forward. But the current initiative started in 2010 with a presentation to what was the precursor of the Health Quality and Safety Commission. It was called the Quality Improvement Committee, and Grant Christie and I made a presentation. This is a couple of slides from the presentation talking about the benefits of a trauma system: lower mortality, less morbidity, patient-centred care, a non-geopolitical model. I don't think we've quite got there yet. Inter-service coordination and raising the bar from everyone. And almost within a month of making this presentation to the Quality Improvement Committee, the Quality Improvement Committee was disbanded, and we thought, oh God, it's happened again. The same thing over and over again. Fortunately, HQSC was formed, and the drive and the acceptance, both by this Quality Improvement Committee and subsequently by the DHBs, to develop a network actually proceeded. And so these were a couple of the other things. We talked about national and regional systems, verification, which is something we did nationally recently, sensible guidelines, audit loops, education and training, which of course is part of what you're doing tonight. And as a result of that, the National Health Board initiated or put major trauma on its list. This is page 2 of the list. You can see table 2 there. We just sneaked in. This is like getting a scholarship by the lowest possible mark that actually gets you over the line. At the end of the day, nobody cares. You're in the list, nobody cares whether you got the top mark or the bottom mark. We got the bottom mark, but it was enough to get us over the line, and it put us on that list of national service improvement programs. And the ACC and the Ministry of Health got together and sponsored the network, which was born in 2012. And the role of the network to provide clinical leadership and oversight, ensure that there is a planned and consistent approach to trauma service care across New Zealand. And consistency is what gives good results. It's not the fact that you might have a spectacular result on one day. It's doing the same thing all the time and getting the right results. The network has 3 main priorities, and by the way, that's the page from our web address, which is majortrauma.co.nz or majortrauma.nz, whichever you like to go to, that's got some information there. It has 3 main priorities, the network. One is the structure, the second is a registry, and the third is consistent guidelines. And so to understand a problem, you need to have data. Somebody once said that trying to do quality improvement without data is trying to play darts without a dartboard. You never quite know whether you're close to the bullseye or not. So some of these things which we didn't know, we now know a lot more of. We formed a registry in 2015 and it started then. Some of it at hospital level. I mean, in Auckland City Hospital, the Starship started the first registry in the early 90s. We've been doing this for a long, long time. But at a national level, it didn't start till July 2015. And we used a standard sort of process, and we got a data set which is similar to what they use in Australia. We got a privacy framework. We based it on a registry that was already running, and we wrote some reports, and we've written it up as a process in the NZMJ if anyone wants to cite it, and we've got some data. And some of the things that we now know across New Zealand is that road crash is over half of major trauma, no surprise. Falls are 26%. We've got quite a lot of assault, and all the others fit into that category. The fact that road crash was a significant part has allowed us to engage with the traffic agencies, AA, NZMTR, MOT, and get them engaged in helping us improve the outcomes. I put paediatric on here just to give you, I put the national figures grey in the middle, the northern figures, which are virtually the same on the left-hand side, and then I took out the paediatric figures. So paediatric, by definition, is the same as we use in this hospital. It's 14 or under. So 15 and over is in the adult category, 14 and under is in the paediatric category. And as you would not be surprised, assault is lower, probably a lot of it domestic violence, I suspect, or a greater proportion of it. Assault is lower in the paediatric group. Road crash is lower and falls are higher. And obviously I wouldn't expect anyone in there to be a driver, but you never know. If you look at the rates of trauma, when we started the network, we drew on data from Canada and Australia, and we said it's very likely there's about 40 per 100,000 per year in New Zealand, and so there'll be roughly just over 2,000 major trauma patients per year, which is exactly what it has turned out to be, just over 2,000. The rates seem to vary. Seem to be we're in a slightly safer rate part of the country, the northern region. I don't quite know the reason for that. And the South Island slightly more dangerous, 52 per 100,000. Doesn't seem to be reflected in the paediatric numbers. You can see the paediatric numbers per 100,000 children are 12 and up to 17 in the central region. I'm not quite sure why that's higher there. These are, but that's actually 3-year figures for paediatrics. So it's as big a number as I can get, because as I'm going to show you, obviously paediatric trauma by that definition is relatively uncommon. We have some really neat tools now. All of the data is matched by GIS, and so we can map trauma over the whole country. I think this is a data set from 15-16, but we can zero down on those. This is obviously an animated thing which I haven't linked up to the internet to animate. So we can map it by type of injury, and we can zero right down. Actually, we can zero down to street address. can actually, which is a bit sort of, so we don't tend to do that because it's just a bit too intrusive, but we can go right down and figure out exactly where every major trauma occurred in a given year. So that's, that is pretty neat. If we look at the incidence, there are actually 3 peaks. The 3 bars on the left of your graph are actually the pediatric definition ones, and you can see it's a very small number. The three peaks are the young and the reckless, which is a sort of 15 to 20 age group. Then there's a middle-aged period of sensibility, which is some of you may be in, which is sort of about 30 to 50. And then the middle-aged and the reckless come along, and they're the group that have just probably bought their Harleys or something like that. They've got money, so they do dangerous things, but with more money than they had before. And then at the other end of the spectrum, older people are still doing stuff which run them risk of major trauma, and so the risks go up there as well.
While we've got some technical difficulties, shall we just do some question and answers again? Are you happy
Absolutely,
with that?
absolutely.
Does anyone have any questions at this stage about the National Major Trauma Network? Or about trauma in general? Yes.
Where are we headed, Prof? What's the future going?
Well, the future has a much more coordinated approach to trauma, and I think regardless of the clinical parochiality that we all have, and I think we're offline now so I can probably say this, but it is the biggest barrier to improvements in care, not for bad reasons, people are not being bad, but they all think they're doing their very best for patients that are close to them. But of course, paediatrics have always been way ahead of the game in terms of many things to do with healthcare and centralisation. But I think the greatest advances will come simply by pre-hospital services using the destination policies that are in place and are developing to deliver more and more patients to centres that provide care for more of them. And I just give an example of spinal cord impairment. That's where I was today, at Spinal Cord Impairment Governance Group. Fortunately, the numbers aren't huge for those. Only 161 last year made spinal cord impaired patients in New Zealand, but they all go to 2 centres. And one of the examples, one of the cases quoted was some guy that was lifting in the gym 140 kilograms of weight, and he misplaced the barbell and it fell on his head, and he immediately couldn't move his legs. This was in Hamilton. So he was taken by ambulance. He had isolated spinal cord injury and was taken to not Waikato Hospital, but the Waikato Hospital helipad, where he was taken directly to Middlemore and had his operation, I think it was 5 hours after his injury. So he had his injury, got taken to the helipad, got brought to Auckland, to Middlemore Hospital, and had his CT scan, which showed a very nasty C5-6 dislocation. He had it reduced and plated, and that all happened in 6 hours, getting to the place where he could get the best outcome. And I think that when you start to discuss things like destination policies, a number of hospitals, some of them bigger, some of them smaller, some clinicians who have moderate experience, some have less, have what I describe as, it's nothing new here, the death by 1,000 cuts syndrome. The death by 1,000 cuts syndrome is if you just stop that one little thing, our hospital, our service, will be completely dysfunctional. So I'm going to resist you changing that one little thing, that thing that might be to do with 2 patients a year. We do very well for those 2 patients. How would you ever show the stats on that in 100 million years? The answer is you probably don't, but it's really hard to actually come up with a definition. But it doesn't matter. We're going to resist like crazy that 2 cases. And I think the way to get round that is exactly what's happened with spinal cord. Once we have that, if you have the debate, people will resist. But if they never see the patients, then they don't even notice that they've gone. And the hospital carries on, and everything's the same. Why not? Because they're very small numbers. So, and I'll show you some numbers of paediatric, I hope I can get to that slide, because it's a number of paediatric cases that go to each of the hospitals. You at the Starship, and presumably many of you come from the Starship, manage 188 of the 350. My memory's working on part of these things anyway. You can see if I'm right when I come to it. 188 of the 350 paediatric major trauma patients in the last 3 years. The other major centres manage 124. That leaves, I think, about 35 for all of the other hospitals, and I'll just show you a bit of data in relation to that in a second. Paediatrics is a small number, so it's likely to be associated with more variation. The fatality rates in overall trauma are highest in what I call the Big Five, which are the middle-sized group of hospitals that don't have a whole lot of trauma and don't have a trivial number of trauma. We're not right there. The same feature is seen in paediatrics. So in the Starship and in the other tertiary centres, there are very low mortality rates. In the other hospitals that are that manage a few, it seems to be quite high, and in the very small hospitals, it's very low. People often say when I present these data, oh, the reason why it's high in those middle-sized hospitals, the patients are really sick. They could never have got to the big hospital anyway. But that would be, if that was the case, it would also be true in the very small hospitals. If the argument is, well, the ambulance service took the patient to the closest hospital because they were so sick they didn't want them to go, couldn't take them anywhere else, it would be true of the small hospitals alone. And we've got this interesting peak of mortality, which we need to investigate more. And I hadn't taken out the paediatric numbers before, but they're even more striking in paediatrics than they are for the trauma numbers as a whole. So really small hospitals, they probably think, oh my God, this is a bad trauma case. Let's get the patient to somewhere quickly, and they do it very well. The bigger hospitals see a lot of trauma patients and do very well, and the Starship's an example of that, and so are paediatric centres and the other major centres. And the middle group is, I think, both in terms of adult trauma and major trauma, where we need to do a little bit of work in terms of, and it won't be upskilling because the people are already skilled, they already are enthusiastic, but it's the volume of work and the facilities. It's the neuro input in particular. It's the anti-haemorrhage things that you've got. It's interventional radiology. It's all of those things in together that influence our ability to provide high quality care.
So we studied kids who went to Middlemore, and half of them turned up to the hospital directly, so we couldn't have done much about that in terms of hospital bypass protocols. So what do you see as the answer to getting these kids out of small hospitals and big hospitals?
That's the other fact, is that for various reasons people end up in a hospital. Sometimes it's that they are taken directly, and sometimes because no triage process is perfect, they're taken, and the bigger the hospital, the harder it is to get somebody out quickly because the more they think they have to do. And it's equally true in Auckland Hospital transferring people to Middlemore as it is vice versa, because you think you have more capability, so you try and do more things. And I think the issue of timing for transfer, how long should somebody be in the hospital? We're sort of getting better of it in adult world with spinal patients now, that where a spinal cord patient, if you like, inadvertently comes into the ED, the patient usually goes straight from the ED, to Middlemore, even without scans, unless Middlemore say, we're a bit busy now, can you quickly flick in a scan before that you send them across? But in general, without that sort of arrangement, a patient comes in. The old days, patient used to come in and say, oh, this patient needs to go to Middlemore. Oh, we better do everything. Oh, God, we couldn't possibly have the patient turn up there and then find the patient's got a fractured ankle and we didn't know about it. So we have to do everything. It takes hours and hours. And in fact, remember years ago when head injuries were an issue, one of our neuro registrars, now a professor of neurosurgery in Perth, did a study looking at the time to transfer, and this is the days before Waikato had neurotrauma, took longer for a patient to get from one metropolitan hospital in Auckland to another than it did to get from Gisborne to Auckland. Because Gisborne said immediately, this patient, it's got a head injury, needs to go to the neurosurgeons, and there's nothing else we can do them here. Let's get them in a plane and get them out. Whereas in the big hospitals, you think, oh, there's all sorts of things we can do. Why don't we do them? And this is some quite big numbers. And although this is only the data from 1 year, the data is the same from all 3 years. Big hospital mortality 9%, regional hospitals 12%, small hospitals 6%. And if we look at, and I apart from Starship, I haven't identified anyone else over here, so I can just sort of say this. If you look at the big numbers, you obviously see the total number of cases. This is for 3 years on the left-hand side. Starship's got 188. Most of those other big numbers, 41, 36, 30, etc., are in the other large hospital category. And the mortalities from Starship, 5%, other large, 2%. And it's just, this is case adjusted, risk adjusted only by virtue of numbers, so I'm not making it out statistically. But it is interesting that in the medium hospitals that have 33 patients, 18% mortality. And in the small hospitals that had a small number of patients, 0% mortality. And I say that, you know, I would make less of this if I just had the pediatric stuff in front of me, but it matches exactly 3 years of adult data as well. And so what this, and you can see those are mortality numbers down the side. 2 and 5 are large hospitals and Starship in particular. And although the numbers are small, we're talking of things like, you know, 5 of 11 or 7 of 15 or whatever. Really nastily big numbers, and I think there is some work to do there in terms of consistency and destination policies. Some of the things that we're looking at in terms of our indicators are mortality, obviously, pre-hospital time, trauma team activations. I don't know what the Starship numbers are, but basically you're looking to have something like 2.5 times the number of activations as there are trauma patients, because if you do that number of activations or trauma calls, you will probably get 98% of your patients seen by the trauma team and you'll miss very few. Blood alcohol is not an issue for you. Time in first facility, we're trying to keep low. Somebody asked, you know, about time. Less than 2 hours as a goal. Time in ED short, and time to CT if necessary. I was going to compare us a little bit with Australia, but I won't, except just to flick through the slides. 10% mortality in Australia. This is the ATR, this is the Australian Trauma Registry, which looks at an equivalent of just tertiary hospitals in Australia. So this doesn't have small ones. But and again, they're a bit sensitive about naming people as well, so they don't put any numbers. And I don't know who A to Z are in particular, but almost certainly 4.1%, 5.4% and 5.6% relate to big children's hospitals, like specific children's hospitals, like Royal Children's, Westmead Children's, etc. And so if you looked at a number like 5% or 4%, that looks sort of normative for Australasia. So I'm very comfortable with the tertiary numbers in terms of mortality that we're seeing here. Some of the times about time to hospital, we do slightly better at getting people to definitive hospital. We take longer to do it. What can we do to make trauma care better? These are things that we can do, I think. Advocacy, training, which you're doing, clinical improvements, regionalisation, which I've spoken about already, and making overall system change. Just an example, just if you have to take a couple of things, you know, you often hear us banging on 2 words, accident and toll, as in road toll, are things that we probably shouldn't use. Accident, because it creates an inevitability about process. An accident is an act of God. It's something that couldn't be happened. Whereas most things that happen, at least in the road traffic area, might be accidental for your patients, but are often not accidents for the people in control. And we should try and drive that out of the lexicon. We'll talk about road crash, because that just describes what happened. It doesn't put a purpose to it. And the toll, I didn't understand this, but when you think about it, a toll is what society agrees to pay as part of doing something. I went up to Walkwith at the weekend, I had to pay the toll. I accepted that because I used that road, I pay the toll. Using road toll in relation to road crash mortality creates a similar perception that it's an inevitable component of using. And I think at times we need more of a Vision Zero, a predator-free New Zealand approach, that an aspirational goal that may not in our heart of hearts be achievable, but drives our thinking in a different direction. And this is just part of it. Advocacy, training, lots of training going on. A lot of it stimulated by the network, and so those are things we've done here. Clinical improvements, some examples. I was a bit disappointed by this, by the way, and I hope I haven't accessed the wrong site, but I looked for the Starship guidelines and I got this and I saw all sorts of good stuff. And then I saw that. It should be reviewed every 2 years, and it was posted in 2012. So It's probably an old website. Regionalisation, I talked about the spinal cord, which I think was one example, and I think we can do more in that regard. Starship obviously has its destination policy. There's the destination flow chart for children in Northland. We have an approved business case from the ACC. It's always a great delight to actually achieve something after many years. We have confirmed funding for 5 years that will fund our registry. That's often a challenge for people, not because they don't end up getting funding year to year, but if you get funded for 2 years, the odds are you'll spend the last 6 months of that 2 years arguing for the funding to start the next time. To have 5 years of funding means that we've got 4.5 years where we don't have to argue about the funding and longer to achieve things. These are some of the things that we'll be able to do: workforce, trauma research, the registry, analytics, informing policy. And I think that's the last slide. I can tell you that paediatrics functions very well within the overall concept of the National Registry. You've been a national network. You've been doing network stuff long before everyone else has done. We need to bring the whole trauma care provision into line, and there's a little bit of work that can be done in very sensitive areas about more regionalisation when it comes to provision of paediatric trauma care, at least for major trauma. So thanks, I won't take any more time.